Good afternoon, everyone. My name is Saif Afat. I'm an attending radiologist from Tübingen. If you don't know, Tübingen is in the south of Germany. And I will be doing this presentation with my colleague, Andreas. We will be speaking about our research collaboration with ClariPi and assessing this tool and even being creative in using AI, but not only making images prettier, but also trying to implement it in workflows. We will be first speaking about the denoising part, how it works and how we looked into this, and then we will have a couple of use cases like cone beam CT and how it can improve automated workflows. And at the end, we will be talking about some future projects or some ideas what we have. So, Andreas, the stage is yours.
Thank you very much. I hope my mic is working. Thank you very much. As you all heard, I'm his colleague. He's a board-certified radiologist. I'm just shy of becoming a board-certified radiologist, but we're both deeply into low-dose CT research and denoising. And the connection between image quality loss and radiation dose is always drilled into us as assistants, but you never really see it in patients. You always get told about it, but you never really do see it. And if you want to see it, you have to take detours over phantom studies, or in this case, what we did here, this is an animal study with pigs, where we scanned consecutively low-dose spirals, so we could really see the quality loss in CT when reducing radiation dose. So this is with regular iterative reconstruction strength 2, what we have in our clinical routine. As you heard, we have a strong research collaboration with ClariPi. So here you can see denoised data sets from the same pigs, and as you can see, I mean, this is not yet published. It's a paper from one of my PhD students, so this has to be between us here, but I can tell you right now that radiation dose... Oh, wow, the pointer isn't working. Okay, well, maybe not. The image quality between 25% and 100% is really, really fairly similar in the real low-dose data set. But of course, we can't do low-dose imaging in patients, really, because you have to really check for quality losses, and you have to be really certain that you don't lose quality of your study. So luckily, what we have available to us is good low-dose simulation tools, and those are really good. Well, how good are they? Well, we even asked that ourselves, and this next part is going to be presented by Saif.
So what we did next, we wanted to see how good are the real low-dose images compared to DICOM simulation and to raw data simulation. And we did a similarity index on both data sets compared to the original measured CT images, and there wasn't a voxel-wise, and it wasn't a huge difference between them. And then we moved forward and looked now to use cases. One of the regions what radiologist doesn't like that much is imaging of head and neck. And what we saw is you can go down to 25% of the original dose, and using AI denoising, then you can still see it compared to the original one. So this is the 25% denoised, AI denoised, and this is the original one with iterative reconstruction from our vendor. The same thing we checked or we looked at in abdominal imaging. Actually, the same message. You can still, with 25%, see very similar images to 100% with iterative reconstruction, the vendor reconstruction. And our colleague had a rotation in the neuroradiology, so...
Yes. which is funny because right here is one of my superiors from neuroradiology. Usually, neuroradiology is one of the last steps you go into when you're an assistant in Germany. But for us, it's really funny because when you go to neuroradiology, it feels like you're new to radiology altogether. You're so used to looking at abdominal CT and MRI, but you never really look at the brain. And then you start again with brain imaging, and of course, well, while I was there, I started to get into the topic here too. So here we have brain scans at 100% and 25% iterative reconstruction dose, and these are the denoise data sets. And as you can see, of course, there's a huge quality improvement in the 25% radiation dose data sets, where it's even possible to accurately delineate, this one was a staging CT, the new metastasis on the right insular region here. So this is a really good example of the capacities of denoising in this context. I'm going to go on here because the next one is sort of my topic right now as well. Right now I'm in interventional radiology, so of course I'm looking into denoising in interventional radiology as well. Usually the flat panel detectors have a different noise distribution from CT detectors, so it's not as easily to anticipate whether the denoising will work there as well. But as you can see here, this is an example from a 6-second cone beam CT scan and a 3-second cone beam CT scan. Well, of course, it looks better, but why is that important in this regard? Usually in interventional radiology, when you do bronchial artery embolizations, you use cone beam CT to localize the outlets of the bronchial arteries and their trajectories to improve the fluoroscopic guidance in that part. You can do 6-second runs in C-arm cone beam CT, which have fairly high image quality, but also unfortunately have a fairly high motion artifact burden. But also you can do 3-second cone beam CT, which have higher noise but less motion artifacts. Well, we looked at this specific example here, and as you can see in the denoise data sets, of course, 6 seconds and 3 seconds both look better than the original data sets. But of course, in the 3-second data sets here, you have the possibility of also reducing noise in per se reduced motion artifacts data sets. So this is not only an example where you can really decrease radiation dose for the patients, but you can also really improve quality of life for the interventional radiologist when using this technique. The next big topic is workflow studies, which will again be presented by my colleague Saif Afat.
So, as I said at the beginning, we looked into workflows, so we looked a bit more creative, not only getting the image quality better, but also trying to improve workflows. So one of our workflows, what we tested is, we're not going to talk about how the images got better. We will be talking about if we do cardiac CT and we load it, we use Siemens Singovia for calcium scoring, for example. And if you did it once, you know that you might do some corrections. The software will detect some plaques and others not, or the vice versa. And what we noticed, if we do an AI denoising on the data set and then we run a single via workflow, it works smoother. We even stopped the time, and it was significantly better with AI denoised images. You don't have to correct that much from the automatic detection software. So this is like another field of the AI denoising. It's not only about getting the images better, but also making the life of a radiologist easier. This is an example what we found very interesting. On the left side, you can see this is the standard CT without AI denoising, and the software missed a branch. And with AI denoising, you can see it. Still in the standard denoising, you can actually correct it so it can see it, but with the AI denoising, you have to correct much less. The same workflow actually we did with perfusion CT from the lever, and what you can see, there are less artifacts on the right side, and also it is easier to use, so you don't have to correct things or the automatic detection of the portal venous or something like this. You don't have to do it anymore or less. And I give it now. I think it's your part.
Yes, it's my turn again. Thank you very much. Going back to when I was new in neuroradiology, I wanted to show this image again because it's not only a case for low-dose denoising, but it's also a case for workflow improvement. Because the way I remember it, I found it really hard in the beginning to sort of look at the regular brain CT scans. But when I looked at the regular 100% denoise data sets, I found it fairly easy. And this is another case for a workflow study where it's really easy for the reading radiologist to perform better and to read the image faster. And I'm going to finish up here with sort of an outlook. What haven't we talked about so far? Of course, it's photon counting CT, the new technology in CT, the new kid on the block. There are several caveats so far, and the first one is, of course, the noise distribution in photon counting detectors is significantly different to that of energy integrating detectors, and therefore denoising softwares are difficult to anticipate. And so far, of course, there is no low-dose simulation method for photon counting CT, which, of course, from Siemens' side is probably because there is little capacity right now. But what do we have? Of course, we have the capacity. So we thought about what we should do to get to know it. And this is because this is where we did some brainstorming, and we did some whole body cadaver scans on different radiation dose levels. This is what the IQ levels are for. If you set the KV level, this is sort of the MAS setting, which you knew from your previous scanners. And of course, we did reconstructions in a soft kernel and a hard kernel, and in FBP mode, and in our sort of newer iterative reconstruction mode, which is native to the Neotome Alpha. So, in case anyone counted here, of course we did any combination of the scan and reconstruction. So this is 32 reconstructions per cadaver scan, and we did 4 cadaver scans, so quite a lot of data, which of course will be sufficient to sort of improve the model and get to a low-dose denoising model and get to a low-dose simulation and a denoising model on the Neotome Alpha. And why is that needed? Here you can see some preliminary results. Of course, the images look better even at 25% denoising. It looks better than at 25% regular, but noise distribution is sort of different right now. So that is something we are still doing active research on with our data sets that we generated. But then, of course, we were talking about if we couldn't get anything more out of the data. And of course, we can by adding even more reconstructions. So what we did here is adding 3 slice thicknesses and 2 matrix sizes. And of course, I guess everybody knows here what we're going for. This is going to be for a special super resolution algorithm that we can use in our clinical practice, because we get a lot of external images from practices in other hospitals that we have to demonstrate, and tumor boards, which certainly do not live up to our standards. So this is kind of what we're at on our weekends. So many projects to come, many interesting things to come, and we're happy for our collaboration with ClariPi. Thank you very much.
Gentlemen, thank you. Some fascinating results there. A quick question, if I may. One of the key principles of radiation safety is ALARA, as low as reasonably achievable. Clearly, this technology allows us to achieve lower dose radiation than is currently standard. Do you think there will come a time that under the ALARA principle, this kind of technology will almost become mandatory?
Yes, I do think so. I think it's a bit off. It's going to take a while, because when iterative reconstruction algorithms were new, you had to do thorough clinical investigations. where you could even sometimes see that higher iterative reconstruction strengths sort of invented new liver lesions. There's a fairly prominent radiology publication for that. So I think after a certain grace period where we can do our clinical evaluations of the algorithm, absolutely, of course.
We have a study where we prospectively had patients with abdominal pain. They underwent a low-dose CT and a full body, a normal CT protocol, and we noticed it's almost the half what we had in radiation dose, and we can detect all lesions actually what you can see in a normal CT. So I think it will take time, like my colleague said, but it will come.
And then my follow-up question,
Yes.
a bit more controversial. Is this the death of the X-ray?
In some fields, yes.
Yes.
Yes. I think in some fields you will be going lower than X-ray, then X-ray will be obsolete. So it's my personal opinion. I think in some fields you will be taken over with CT.
I imagine the emergency physicians will be salivating and having a CT on every single patient who comes through their door. Do you have a question?
Yes.
Get your microphone working.
Can you hear me? Yeah. So my question was, in the area of AI, is there really a need to have more beautiful images? Because what you show is that those reconstruction, they do not make appear some lesions that was not visible on the low dose CT scan. So this is just for human eye. Do you think there is a rationale in the area of AI?
Of course. Of course, and what you're insinuating here is a good argument, because of course the overarching goal of us all here will be for the algorithm to do our reporting someday, and when hopefully we all have secure jobs. But this is far off. This is really, really far off. We have certain algorithms which we saw today. We have other algorithms which we use in our research for labeling and for creating sort of voxel maps. But none of these really work for every kind of clinical example so far. And the kind of computational power that you would need for an algorithm to really outperform a radiologist in every piece of work and in every aspect is so high that it's so far unachievable. Maybe someday in the future, when quantum computing has become sort of the main computing that every sort of hospital has, maybe then. But so far, I think it's sort of a good way to go.
I have a small comment on this. So it's actually not only about making images prettier. This is why we are trying to be creative, how to make our lives better while we're working as radiologists. But it is, like you said at the beginning, it's ALARA principle at the end. So it's not only making it prettier, but if a patient has a staging CT and he gets it every 3 months, and you can give him 25% of the radiation dose, this is huge actually. If you look at it in the long term, like it's staging over 3 years, every 3 months. So this is actually where the impact is. I totally agree. You see the lesion, it's 1 centimeter. You make the image prettier, it's still 1 centimeter. It doesn't matter. But at the end, the radiation dose matters and the workflows matters.
Thank you very much. Do we have any questions from the audience on this excellent piece of low-dose research? Nobody's putting their hands up. But gentlemen, thank you so much. Another round of applause, please, and please take your seats. Thank you.